you when you came to visit us here. We got a lot of information. It was informative and, as you say, also transformative. A lot of what you told us has already been put into practice. And I appreciate your taking the time this morning to answer some of the follow-up questions from the intern class. So with that being said, I'm just going to let you get started.
All right. Well, thank you. Hello, everybody. Good morning.
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 So my question actually for you from a process, Cheryl had sent me a list of questions to go over, and I can either just go through them as much as we can. I think we have about 20 or 25 minutes, if that's right. Or we can turn the computer around to whomever asked the question. So is there a preference, or shall I just get started?
I think we were discussing just having you go through the questions we had for you.
All right. Well, let's do that. So they were really good questions, actually. I don't know that we'll get through all of them in 20 or 25 minutes, but I'll go ahead and offer some thoughts on some of them. The first one, these come from Maria, and she asks, what are my thoughts on buprenorphine orally in dogs? And I assume, and Maria, if you're there, is Maria there?
Yes, sir.
Hey, Maria. So I assume you mean buprenorphine oral transmucosal, correct? Not swallowing it, but
yes, sir.
squirting into the mouth. So actually, this work has been done, and there are a couple of data points to share with you. And the first is that in a kind of an experimental model, just kind of squirting it into the mouth with a kind of a spray model, let me just give you the bioavailability, and that's about 50%. So if you take the injectable Buprenex and you squirt it in the mouth of a dog, you're going to get about 50% bioavailable. That is about the same as humans, because it does occur. You can get buprenorphine suckers and things like that. These are people who are often coming for addiction purposes as a replacement, but also in cats. And I know we were once taught that by squirting it into the mouth of a cat, pardon me, that we have like 98% bioavailable. But the problem with that study is that the model was to squirt it in the mouth and then to draw blood from the jugular vein. So obviously the plasma levels are going to be very high if you do that. It doesn't account for a first pass effect. And when that study was repeated using arterial blood, which accounts for that first pass effect, then in fact then we do get a bioavailability of, guess what, about 50%. So really it's about the same for dogs and cats and people, oral transmucosal route. So it can work, and in fact the next data point is the one that had a actual test, and it was using oral transmucosal buprenorphine in the dog to a clinical effect, and it worked. It was adequate as a preoperative opioid for a spay model in the dog. Now the problem is, from your perspective and to the clinical utility of it, is that it was a really high dose, 120 micrograms per kilogram, or 0.12 micrograms per kilogram. And if you want to do the math and calculate that out with using Buprenex, a 20-pound dog, so that's a 20-kilogram dog, so let's say about a 40-pound dog, 20 kilograms, 0.12 mg per kg. The solution itself is 0.3 milligrams per ml. You're talking about, let's see, I did the math, it's about 8 cc's. So if you want to squirt 8 cc's of Buprenex into a dog's mouth and hope to get some kind of clinical effect, by all means. But the reality of it, that's too big of a volume to make it financially practical to do. Number two is that I don't know that it's all going to stay oral transmucosal. Surely they're going to swallow some of that, and that's not going to work. And then you have another huge first pass effect because it gets cleared way out of the liver before it hits circulation. So the answer to your question is, can it be done? Yes. Ought it to be done? Is it a practical clinical tool in the dog? Probably not. And I don't know anybody that's making the case for doing it on any kind of routine basis. Does that help? Does that answer your question?
Yes, sir. Thank you.
All right. Well, you're welcome. All right. So the next question was thoughts on pain medications to go home. And I maybe this ought to be compartmentalized a little bit, because It doesn't specify the species, but let's assume for the moment that we're talking about dogs, and I also assume that we're talking about post-surgically, post-op. Is that correct?
Yes, sir.
All right, good. So you gave me a list of, I think, tramadol, you gave me gabapentin, you gave me acetaminophen with an opioid, and I'll go over all that. What you failed to put down here, so I'm just going to go ahead and prompt this, is nonsteroidals. So I'll just ask you, Maria, is there a particular reason that you wanted to not really talk about nonsteroidals, or is this instead of or in addition to?
I guess kind of instead of.
Okay.
I always, when I'm sending them home, wonder what to send home, is to go home meds. So kind of instead of what to send home.
All right. So I'll answer with each of those drugs, in fact, but I'm going to challenge you a little bit. So why not nonsteroidals? Why instead of in addition to?
I mean, in addition to would be fine.
Okay.
Yeah, in addition to.
Okay. Well, the reason I'm making that point is because the surgical pain at its core is inflammatory pain, and you just can't get around that. And if you're trying to use pain-modifying medications without a nonsteroidal, you're really kind of rolling uphill. Keep in mind that nonsteroidals have both a anti-inflammatory effect, but it also has a central analgesic effect, both at the level of the spinal cord, but also up in the brain. So you really need a nonsteroidal unless it's absolutely contraindicated, and there's going to be only few and far between cases, in my estimation, where nonsteroidals are simply not to be used, either in that immediate perioperative period or going home. So I'll just continue to make the case that nonsteroidals, insofar as it's possible to do, remain a critical, if not the critical point or medication to go home for surgical pain. Okay. Now, on the particular drugs that you mentioned, let's go down this list. And when I was at River, I actually gave this in a bit of a PowerPoint, and I can actually I'm going to go over these bullet points. This is like a really brief summary of the data that I shared, and if you like, I will send you maybe just a few notes that articulate out, and you can see the citations or the references of what I'm getting ready to tell you. Are you ready?
Mm-hmm.
All right. Tramadol. No, let's not talk about tramadol. No, we'll talk about that. Tramadol. Number one, low plasma levels in the dog. For example, I'm 200 pounds, 100 kilograms, let's say. And if I take 1 milligram per kilogram, I'm going to have a plasma level of 309 nanograms per ml. You give dogs 10 mg per kg, 10 times a dose. Plasma levels in the dogs are more like 39 nanograms per ml. It's a tiny fraction of what gets into the human blood. What gets into human plasma has a very short half-life. So in humans, 5.5 hours, and in dogs, between 1 and 2 hours, depending if it's the parent drug or metabolite. So very, very short relative to humans. It's not an opioid, unlike in humans that produces an opioid metabolite called the O-desmethyl tramadol metabolite, the M1 metabolite. Dogs don't make that metabolite. Number 4, if you give oral tramadol sequentially over several days, there are 2 studies that demonstrate that as you give it, the plasma levels, which are miserable to begin with, go down, 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 down. They are essentially have absent plasma levels after a few days. So in particular, trying to give it chronically, it seems to be almost hopeless in terms of what's actually doing for the dog. 5, there's no safety data, there's no toxicity data, there's no dose titration data. The adverse events are probably more significant and more frequent than we give it credit for because we don't track it, we don't really know. On the human side, the adverse events include GI upset, just like nonsteroidals. So if you're giving it the 2 together and then they don't eat well or they spit up, what do you know? Which one is doing it? We don't know. What else? Hypertension, seizure potentiation. If there is a GI erosion or bleeding, let's say an ulcer, the bleeding from it will be worse. That's demonstrable in humans. That's because the other metabolite of tramadol enhances serotonin and norepinephrine, which are inhibitory neurotransmitters, but it also messes around with platelets. So you have increased serotonin, and you have basically a decreased coagulation, so the bleed's worse if there happens to be an ulcer. And there is some vague concern. There's nothing for certain about maybe the safety of combining it with a non-steroidal in the first place, just in terms of those GI adverse events. So I just asked the question back to you. Given I'm just going to add number 6. We don't have any clinical data that oral tramadol works in adults. We don't. There's one little mechanical threshold study and using 6 greyhounds, and the mechanical threshold went up a little bit, tiny bit, but only at the 5 or 6 hour time period, and that's at 10 mg per kg. So if I give you all this stuff, and we have no clinical data, not very helpful mechanical threshold study, and we have all this other stuff in the pharmacokinetics, I don't know what else I got to do to make you skeptical about whether or not oral tramadol is going to work postoperatively, or especially using it chronically. That's not to say, by the way, for everybody in the room, that tramadol doesn't work, because we have other studies using it intravenously, epidural, and subcutaneous, that it can work, that it can have a pain-modifying effect. I'm just saying that when we use it orally, and for whatever reason, either because of these terrible plasma levels, if maybe there's saturation of binding sites, maybe first pass effect, who knows, that it can't. I just don't find any evidence or any sense that it's going to have any significant pain modifying effect. Now, to the extent that you want to use it, you can. I know it's very popular, and I also know that there are folks that will swear, I dispense it, I see it, it works. My clients tell me it works, and we all have felt that for a long time, myself included. But there's a huge, huge caregiver placebo effect. It's 35, 40, 45% in dogs. And cats, the same placebo effect for pain is like 80%. The dog's placebo effect, the caregiver placebo effect is published. The cat one has not been published. Nevertheless, anytime you dispense something, up to half the time you do it, you're going to think that you're doing something positive. Does that make sense?
Yes, sir.
So you can't rely on your just empirical, I did it and it worked, and therefore, ergo, it does, because you have to have skepticism about that too. That's your frontal cortex, folks, not your amygdala. All right? All right. Tramadol. Any other questions on tramadol? All right. Gabapentin. Oh, so you did ask a question, or somebody did, or Teresa did. She says, how efficacious is tramadol, and when would I use it? And I'll go ahead and say, because even I am not going to say like I never use it. I will say that I have ceased to use it to any of the degree that we once did. If I use it, I'm at the doses probably higher than you're used to. So you see published like 3 to 5 mg per kg. Well, if you're going to hope to have any effect, at least based on that little bitty mechanical threshold study, you've got to push it up to 10 mg per kg or get up in that vicinity. And I'll say that if you do that, you do have to be more careful or more mindful of adverse events. You're more likely to see them, all of them. So I'll just leave it at that. Teresa, does that answer your question?
Yeah, I just had another question about, I've heard it has like a sedative effect as well, and I've kind of seen in my experience it keeps them more quiet after surgery. Would you ever recommend it for that?
No. In fact, I think that sedative effect, so let's stipulate that the sedative effect that you're seeing is not, or let's say the cognitive effect, okay, because we don't really know what's going on in that head of theirs. That cognitive effect is not from an opioid, because it can cause sedation in human beings, but it also can cause other weird sensations, and I'm wondering if our adults are not experiencing that because of a serotonin norepinephrine effect. In fact, my daughter, some years ago, when she had endometriosis, she had tramadol after her her laparoscopy to clean that stuff up, and she sat there on the couch, and she said she was literally shaking her head, saying, "I don't like this. I don't like this." It really made her feel weird. It did work in her, but it made her feel very weird. So, if you're using it as a sedative effect, I'm going to give you a better alternative. Okay. Sound good?
Mm-hmm.
And I guess I should say, because of that short plasma half-life, if you're using it, you can make the argument it ought to be at least Q6 instead of Q8 or Q12. So I'm just putting it out there. That's just based on the kinetics of it. All right? All right, so let's move on to gabapentin. Gabapentin, in contradistinction to tramadol, actually has very nice bioavailability. We know this in dogs and cats. It has a favorable pharmacokinetic profile when taken orally. The question of whether it has a pain-modifying effect for surgical pain, based in that perioperative period, is, I'm going to say it's open, because I have very spirited discussions with colleagues about what the data says. We don't really know in dogs. I'll just let me give you the stuff in humans first, then I'll tell you what we do or don't know about it in dogs. In humans, you will find many studies looking at it in that perioperative period. Many of them have a negative outcome, and the other ones have positive outcomes. And humans, keep in mind that they can really get a lot more. They can drill much deeper. They can really have much more solid sense of something, whether it's going to be pain modifying or not. For example, obviously we can self-report, so you can give a pain score, number one. And number two, they look at the amount of opioid you're taking, the little patient-controlled analgesia, how much morphine you're giving yourself, or how much you request. So if it has an opioid-sparing effect, that is, you're giving yourself less, that means that you're more comfortable, less painful, relative to not having to study drugs. Does that make sense? So there's all these different outcome measures in humans that they look at that we can't do. So on balance, if you have studies that have positive and negative outcomes, well, the only way to really flesh that out is to look at systematic reviews. And there are a number of them in humans, a bunch of them, and there's even some very recent ones. Really, at the end of the day, when you look at these systematic reviews and throwing out the lousy studies that have poor methodology or some problem with it, and you're left with good, solid studies, the evidence supports that gabapentin in the perioperative period has a pain-modifying effect. That's in humans. In dogs, we have two studies, and neither one of them demonstrated a pain-modifying effect. But number one, the dose in one of those studies was very low. Number two, in both studies, they also had nonsteroidals. They also had opioids. So now we're trying to, in our ability to assess pain, we're trying to, divine out the little extra pain-modifying effect that gabapentin might give. I don't think we have the tools to do it. So an absence of a positive outcome in dogs, in my strong estimation, does not mean that it doesn't work in dogs in a perioperative setting. So how is it used in people, and how have I begun to use it in practice, as well as many others? The doses used in people are in the 5 to 10 mg per kg range. The big side effect of gabapentin is, guess what? What class of drug is it? What is it made for?
For neurologic pain.
Actually, that's not the original label. It does now have a label for that, for fibromyalgia, diabetic neuropathy, but that's not the original class of drug.
Anticonvulsant?
Anticonvulsant, right? So if you look at it, and just to go back over its mechanism of action real quick, just briefly, it downregulates calcium channels, so it makes neural transmission sluggish, and that's why it works in the brain for seizures. But we're talking about its effect in the spinal cord, and along the actual neurons that are coming up to the spinal cord and the ones up to the brain. So when you look at it, as it downregulates those calcium channels, we know it can work for these chronic neuropathic pain conditions, because when we downregulate those calcium channels, that's a synonym for not making as many of the receptors, not making as many of those channels in the dorsal root ganglion, and then not coming down and expressing in the neuron. The question about how fast gabapentin can downregulate these calcium channels, that is, in the surgical setting, in the acute pain setting, is really the open question. Is it causing those calcium channels to just drop back out of expression and dip back into the cytoplasm from the cell membrane, or is there some other mechanism of gabapentin that has an acute effect or an effect in the acute environment rather than the chronic, or in addition to the chronic, I don't think we know the answer to that question. But in humans, when it's done at 5 to 10 mg per kg. Generally, a dose is given preoperatively, a couple of doses postoperatively, and what I'm telling you is that generally it's used in the hospital setting rather than a prescription going home with people. And certainly in our practice, many others, that is increasingly finding traction. It's cheap, it's easy, it's safe, and Teresa, to your question, it is also used as a sleep aid in humans at night, like trazodone sometimes, or Klonopin sometimes. Gabapentin is used for the same purpose. So at 5 to 10 mg per kg, which is a little higher than you would start if you're going to try to get a dog on it for osteoarthritis, because they're going to be on it for a long time, and it will cause some drowsiness at that dose right away. Well, it's not going to knock them out. It doesn't flatten them, but it gives them a nicer time. It gives them a nicer night's sleep. So if I'm using it to keep them quiet, if I'm using it to make sure that I have confidence that evening when they go home, that I'm not going to get a call on my cell phone about a dog that's agitated and not doing well, well, gabapentin is my drug, not tramadol. Okay? So that's my little spiel on gabapentin. Any other questions? All right. Let's move on. I think the next one was acetaminophen and codeine specifically. And we have to compartmentalize out our discussion because acetaminophen is acetaminophen, and then we have these oral opioids. And I'm going to go ahead and start off with the oral opioids. Oral opioids, you probably are already aware, have some limitations in dogs because there is a really, really robust first pass effect, much more robust in the dog relative to human beings. So when we take oral morphine, for example, the bioavailability of it compared to, it's like tiny, it's like 20% of what people might take. Even the per rectal route is about the same. So when we take it orally in dogs, we can't just mix and match in the same way they do in people. However, there's a couple of opioids, oral opioids, that have some pharmacokinetic rationale for using it orally. Start off with codeine. Codeine in humans, when you take it, gets converted almost 100% over to morphine. That does not happen in the dog. And in fact, the bioavailability of that parent compound of codeine is like 4% when taken orally. Very, very low. Negligible. Practically zero. But it makes a metabolite. It makes a metabolite, and if you really want to know the name, it's called codeine 6-glucuronide. That metabolite is produced in very high amounts, and it is an opioid. It has mu agonist activity. How do we know that? Because the effects of it can be reversed by naloxone. And dogs make a good bit of that. Now, the half-life is rather short. It's a 1 to 2 hours. But nevertheless, there's some kinetic rationale to use oral codeine in the dog. The other one is hydrocodone. It also has a rather short half-life, 1.5 hours. There is an active metabolite that has a little longer one at 3 hours or so. It has about 50% of the bioavailability that it does in people, which means it's not going to have the analgesic punch that hydrocodone has in humans, but it can prospectively have an effect or have a utility. There are no, insofar as I'm aware, no clinical data using oral codeine or oral hydrocodone in the dog. Nevertheless, we have this pharmacokinetic rationale for its use. So these are essentially, when you combine it with acetaminophen, these are the generic forms of Tylenol 3 in the case of codeine, Vicodin, and Loratab in the case of hydrocodone. So let me pause there before I move on to acetaminophen. Any questions on the oral opioids? Okay. I want to circle back, and remind me, please, to circle back to long-acting opioids or longer-acting opioids before we get off here. When it comes to acetaminophen, you probably know is like the most popular analgesic drug in the world. It's the most popular on the planet. Maybe the solar system, and probably the entire cosmos. And if it's so commonly used in human beings, I'm going to ask a question. It's not rhetorical. Why don't we use it more in veterinary medicine, in dogs? Not cats, obviously. Why don't we use it in dogs with tremendous frequency, much less at all? What's the answer to that question?
I'd never used it before until I got to this clinic. So, have y'all had experience?
Nope. I've always, all I've ever really known about acetaminophen is don't give it to cats.
Don't give it to cats. Yeah.
So my question to you two then, since you're front and center on my screen here, so I appreciate that you're using it there, and we'll talk about it and the rationale for it. But why wasn't it used? And I know you were in school and everything, but why was it like, just no, you can't, acetaminophen, no, in dogs? We understand why in cats, but why was it so terrible or seemingly, problematic that you would not even think about using it in a dog?
I mean, maybe the only thing I can think of is, if you prescribe it, then maybe the owners will think from there, oh, well, we can just give it to them.
Okay.
He doesn't have pain or anything. So
that's fair. I actually would take that under advisement, and I would support that, actually. Acetaminophen by itself.
Right.
I don't want people going to the pharmacy and just picking up, Tylenol to give their dog.
Right.
What's the other reason? What's the reason why we don't do lots of stuff? And we don't use, let's say, what is it?
We're afraid of it.
You're afraid of it. You're afraid of everything. You're afraid of alpha-2s. You're afraid of non-steroidals. We're afraid of opioids. We're afraid of every damn thing. Oh, this is being recorded. Let me do that again. That we're afraid of everything. And a lot of that fear is where? Is it up at the frontal cortex? No, it's right here. It's the base of the brain. It's up in the amygdala. So let's go ahead and say, what would be the potential adverse effect of acetaminophen that we're so afraid of? What's the big concern?
Liver.
Yeah,
Liver, because that's what happens in people. So guess what? Turns out dogs don't make that metabolite, the one that screws up the liver. Furthermore, dogs do not drink alcohol, at least usually.
Okay.
So they're not having any of the risk factors that that human beings might have. There is one study. If you type in, go to PubMed right now and type in, acetaminophen, toxicity, dogs, are you going to find, case reports? Yeah, sure, of course. And there is one study where the main side effect was hepatotoxicity. That was using acetaminophen at very high doses IV, because that researcher was trying to recreate the model for hepatotoxicity in the dog, for, study treatments for humans. So it turns out that dogs make very little of that metabolite. The metabolite that they do make is the same one that cats make. So when you look at the toxicity reports in dogs, whether it's acute, that is the dog was given a bunch of it, maybe got into a bottle that spilled, or got into a bottle and ate a bunch of pills, or that somebody was giving it chronically for a long period of time, guess what the side effects were? It was the same thing you see in cats, just not nearly as severe. Metahemoglobinemia, anemia, hemolysis, that type of stuff. So it's really hematologic, much like cats, just not anywhere to the degree. And in fact, one study going back a few years, I would say, at 100 mg per kg, had no toxic effects. Mildly toxic at 200 mg per kg. And what's the dose for humans and what you'll see in plums? 10 to 15 mg per kg. You would have to give a lot of acetaminophen by accident in order to see some of the stuff that's in the literature. So really, from an adverse event standpoint, acetaminophen, I'll just say it pretty plainly as I can, acetaminophen, there's really no special proclivity for hepatotoxicity in the dog, and really requires a lot of drug to get toxic effects. So on balance, acetaminophen can be given reasonably safely, and I would say if it's used judiciously, you're good to go. So that's why this clinic is actually using it. Now, it doesn't have any anti-inflammatory effect. It's not to be used instead of a nonsteroidal unless you really absolutely cannot use a nonsteroidal. And for those who will say, well, I don't want to use a nonsteroidal in this case, I often challenge that. What is it about that case that makes you not want to use nonsteroidal? And I'll sometimes say that's not a really good reason, or that you're worrying too much. So when I use these drugs, I use them in this way. They're in addition to other medications. I don't prescribe it, Q6 or Q8, over a period of days or months or whatever. I use it for breakthrough pain. So if I have a patient that I know is particularly painful, if I have a patient that is prospectively painful, going out the door, what I will often do is give the owners the prescription for the acetaminophen, codeine, or acetaminophen hydrocodone, and they have it. And if they have a problem that night, and the extra dose of gabapentin doesn't work, they often have that too, then they can go get that filled, or I'll call it in or something. And they can use it for breakthrough pain, and that is how I use it. This also gets around the idea about people being casual about acetaminophen, because now it's my control. I have control of it. It's not over the counter, and they only get it when I tell them to get it. So that's how I avoid the casual nature of thinking about it. Okay? So there you go. I think there was a particular question from one of you about how safe acetaminophen and codeine might be to use in trauma patients when you're worried about GI perforation, and or in trauma patients, or GI perforation. So recognizing that trauma patients may be prone to GI perforation, but you may have GI perforation anyway, or you may have a GI erosion or ulcer, and certainly in those cases, you have to come off this nonsteroidal, right? Trauma patients with hypotension and hypovolemia, you don't want to use nonsteroidals. So I do think those are two good classes of drugs that this may have applications in. So I'll leave it there. I would say that that is a reasonable alternative when you have patients that I think we would all agree nonsteroidals have to be used either cautiously or not at all. And those are, I think, two good populations. Okay? Any questions on this particular class of drugs? All right. How are we doing on time, Cheryl?
Well, I think that's a question for Ravi.
We're okay.
Are we okay?
Up to you.
Excuse me. So how about one more question?
Okay. All right.
Well,
I think the one I'll skip down to is Andrew. And am I looking at Andrew?
Right here.
Okay. Oh, Andrew. All right. Georgia grad, right?
Auburn.
Auburn. Oh, that's right. That's right.
Yeah.
All right. I'll talk slow. Okay.
It's okay. It's being recorded. I'll watch it later.
Okay. All right. So the question was changes in recommendations for COX-2 selective inhibitors versus the mixed COX-1 and COX-2. So just defining our terms a little bit, it can get a little confusing if we're not really clear. So nonsteroidals will inhibit COX cyclooxygenase enzymes, a spectrum of them. It is the standard kind of nonsteroidals that we do are what we call the balanced nonsteroidals, which inhibit COX-1 and COX-2 to the relative same degree. COX-1 and COX-2, we were taught when these drugs came out, so this is the 90s, that there was a fairly rigid approach to what these drugs do based on in vitro studies in terms of the degree of suppression of COX-1 versus COX-2. As a matter of fact, all non-steroidals become non-selective the higher the dose, so it's a dose-dependent effect. So when you think about COX-1, COX-2 selectivity or COX-1, COX-2 sparing effect, I want to kind of work in some uber concepts, some high-level concepts, that how these drugs work in an individual is really, really, really going to be quite variable. It has to do with individual gene expression. Your cyclooxygenase enzymes will change over time and circumstances. They may change because of the where you have your pain, the reason you have your pain, how long you've had your pain, It will be different from individual to individual. So it is never, in fact, I would say the only thing that we have control of when we're thinking about suppressing COX enzymes is which one we're using and the dose at which we're using it. And even that can change how COX selective or how much effect you're having on COX-1 versus COX-2. So here's what I'm going to tell you in very, very broadly based summary remarks about this question of COX selectivity or COX sparing effect. These conclusions are drawn from several really, really, really good, extensive, systematic reviews of nonsteroidals in veterinary medicine in dogs. This is one of these few domains that we actually have really, really high-level evidence in terms of these systematic effects. I think some of y'all took a picture of one of them that was a Montero Stegall that came out last year, particularly in the adverse effect issue. There's Kukanich in 2012 and Ennis in 2010. But they kind of draw some of the same conclusions. It goes something like this: that the total level of non-steroidal related toxicity appears to be the same for all veterinary approved non-steroidals. In other words, there is not one that kind of percolates to the top of having more problems, or another one that is more safe than the others. And that's why you'll never have the reps of these companies come and try to make the claim, because the claim cannot be made. Not just because of the data that's in the FOI or the Freedom of Information, but this is the totality of data. We're talking about the FOI stuff. We're talking about independent studies, peer-reviewed literature. We're talking about reports to CVM. We're talking about the same equivalent of data that coming out of Europe for the analogous agencies. It may be true that different types of nonsteroidals have a different adverse effect profile, that they tend to do different things, but even that is uncertain. We do know that the veterinary-approved nonsteroidals are significantly safer than the non-approved nonsteroidals. And in that class, we're talking about aspirin, ibuprofen, naproxen, and PS, the Mobic, which is the generic form or the human form of meloxicam, because it's very inexpensive, and so people use it on their dogs. But all of those drugs are significantly less safe than the veterinary-approved ones. We also know the risk factors for problems. The risks of nonsteroidals, and the veterinary nonsteroidals are safe, they're effective, and they're safe, that where there is an adverse effect, most of the time, the frequency and certainly the severity of it can be minimized, if not eliminated, by appropriate use. The data is pretty clear that most of the time, when there's an issue with a nonsteroidal, it is because it has been used inappropriately. And maybe I'll finish up by talking about just define appropriate use a little bit more. And those are things you're going to want to jot down, because if you want to avoid issues, there's a few easy steps to take. In that Kukanich study, I actually took the liberty of pulling this up because these two statements seem to be contradictory, but they're not. And this speaks more directly to the COX-1 versus COX-2 issue. So I'm quoting from him. No extensive studies i.e. that they're properly designed, crossover randomized, of clinical dogs using all available nonsteroidals. There are no extensive studies using all of the veterinary drugs, but existing studies suggest that the COX-1 sparing nonsteroidals produce a lower frequency of GI lesions than the more balanced nonsteroidals. So let me repeat that. The COX-1 sparing nonsteroidals produce a lower frequency of GI lesions than the more balanced ones, than the non-sparing ones. Here's the other side of the coin. Studies also suggest that the more highly COX-2 selective inhibitors may actually produce more adverse effects when underlying gastric damage is present. Let me repeat that. That the more highly COX-2 selective inhibitors may actually produce more adverse effects when underlying gastric damage is present. So the COX-2 selective drugs, or COX-1 sparing, those are synonyms, produce a lower frequency of GI lesions, but if there's a GI lesion, the more COX-2 selective drugs may cause more adverse events. I hope that makes sense. There's a reason for that. And the reason is that there is an inherent, you all dogs, we all have an inherent cytoprotective mechanism in our GI tract. So that if there is damage to the mucosa, there is a way that the GI mucosa will try to repair that. That mechanism, that cytoprotective mechanism, is mediated by, guess what? Cytoprotective / tissue healing is mediated by COX-2. So if you have an existing damage and the body's trying to repair that and protect that, and then you're giving a very highly COX-2 selective drug, you're stripping away all that cytoprotective pro-healing effect, and now that lesion, which may be just a tiny little erosion, is more likely to progress to an ulcer. An ulcer more likely to progress to a perf. So what that means is it circles back to the issue of appropriate use. You want to avoid dogs that may already have, GI erosions, GI damage, GI lesions. Certainly your trauma patients you mentioned. Having already given a non-steroidal or a corticosteroid. And by the way, what's the big non-steroidal that'll sneak in there that you won't know unless you ask about it? That owners are giving that you don't know unless you ask.
Aspirin.
Aspirin, thank you very much. And P.S., aspirin is a unique molecule. It has its own. Aspirin is really unique for two reasons, for multiple reasons. Here are the two main ones. Number one, it will inhibit COX enzymes, COX-1 and COX-2, but it does it in a reversible way, like all of our veterinary ones do, but it also does it on an irreversible way. It acetylates it, and so it causes that cell to that GI mucosal cell to die. In order for it to, the effect of the aspirin to be gone, you have to wait for not just the drug to go away, but you have to wait for all of those cells to go away. So basically those GI mucosal cells have to go ahead and slough off, and good healthy ones come in behind it. That's why the withdrawal time for aspirin is up to like 10 days, because it takes that long to turn over the GI tract. That's one way. The other is that it produces its own cytoprotective mechanism. It's called an AIL or an ATL. That's called a aspirin-induced lipoxin or aspirin-triggered lipoxin. It's another cytoprotective mechanism. Those ATLs basically induce the endothelium to make nitrous oxide. Nitrous oxide keeps neutrophils from sticking to the underlying damaged endothelium. So it's kind of anti-inflammatory in that way, or it keeps it from being more pro-inflammatory. But that mechanism, that ATL mechanism, is mediated by, guess what enzyme? COX-2. So now with aspirin, you've stripped away two pro-healing anti-cytoprotective mechanisms, or two cytoprotective mechanisms you've stripped away. So that's why aspirin in our practice, and it should be in yours too, is like Voldemort. It's just the name you don't mention, because if you worry about people giving Tylenol, indiscriminately, well, aspirin would be far worse, far worse. And if so, a dog is limping, and they've been giving aspirin for a week, and you don't know it unless you ask. Now you're going to put them on, Rimadyl, Deramax, or Previcox. That's, by the way, up the COX-2 selective scale. Now you're just asking for a problem. And the data is very clear that most of the time, the worst GI effects, like perforations that you're going to get, the non-steroidals will have been used in combination with another nonsteroidal, often aspirin, corticosteroids, or at a really high dose for too long, and or some combination of all of that. So that's how we can really minimize the adverse events. So I'll take the liberty now of going through some bullet points of minimizing the prospect and certainly the severity of adverse events. And if you follow these, 6 simple steps, really, I don't want to be like a cosmopolitan magazine, but if you follow these 6 simple steps, really, you're taking a very, very safe class of drug, and you're making it the adverse events. You can never make it 0, of course, but you get really, really close to 0. And if they do have a problem, it won't progress to something severe. So the first step is on this very question of medication history in advance. And this is really the staff. It's the front desk and it's your technical staff asking these questions when they're in the exam room. So what are we trying to be cautious about? Well, obviously, any other COX-inhibiting agent. And you have to ask it in the way that I just mentioned. So is he taking any medicine? No, he's not taking any medicine. How about aspirin? Well, aspirin he's giving, okay? So you have to ask specifically. And guess what supplements, over-the-counter glucosamine chondroitin supplements often have in them? Aspirin. Yeah. So if you've ever had, so y'all are interns, and so you probably haven't had this experience, but I bet Cheryl has. Cheryl, tell me how many times you've had this, that somebody says about their 12-year-old dog, doing pretty well, he was sore earlier in the year, so I went over and I picked up, Super Joint X, Dog X at Costco or something, and boy, he was a lot better in a couple of days. And you're saying to yourself, even if oral glucosamine works in the dog, for having a pain-modifying effect, and I'm not saying it does, but even if we assume that it does, is it going to work in 2 days?
No.
So that means that something else is in it, and the other thing that's in it often is aspirin. So we have to ask, what medications is he on? Any aspirin? No? Okay. How about prednisone? Because people will have a little bottle of prednisone. They're atopic, and so every spring they go and they give a little corticosteroid because it's a 3-year-old bottle, but they give it, and you don't know it unless you ask. And you have to say corticosteroid. You have to say steroid, cortisone. You have to ask it every which way. Prednisone. We also want to watch out for other highly protein-bound drugs. Nonsteroidals are very, very highly protein-bound. So it's not that we know that like giving nonsteroidals along with, let's say, phenobarbital, which is another highly protein-bound drug, is a particular problem. And I go so far as to say it's probably not. But if I have an epileptic and it's on phenobarb, and it's also atopic, so it's on cyclosporin, and it just had a pyoderma, so you gave convenient. All those things are very highly protein-bound. And now he's limping, and I'm going to go ahead and give nonsteroidals. Well, there's only so much albumin to go around. So it gives me some pause, and it should you as well, to be cautious about these mixing and matching drugs. A couple of others to be really cautious about. Obviously, nothing else is nephrotoxic, so aminoglycosides, cisplatin. And then we have furosemide and ACE inhibitors, because a lot of dogs are going to be on ACE inhibitors for proteinuria, furosemide for congestive heart failure. Well, these are potentially problematic. Demonstrably, furosemide and nonsteroidals are a problem together, so I would really not do those two. The GFR really, really drops when you do that. And I would also say that ACE inhibitors does a little push-pull with nonsteroidals. I won't get into the details unless you ask, but I would use them at least cautiously together. We are getting to the point in our practice that we are, I think, going to a point, and maybe you're already there at River because you're a referral institution, but when people are coming in, I think we're getting ready to pull the trigger on a policy whereby we say, just bring your medicine. Just bring everything that you're giving to this dog in a bag, and we'll figure it out. And don't rely on their memory or they're forgetting something. So if you really want to get into it, that's probably the best thing to do. And I would say especially for you all, because you're at a referral and you don't know these patients very well. So I would say that that's a really, really important tool. Just bring in your drugs, bring in your medicines. We'll go through them, and and then you make your notes. So that's number one. Of course, is at the top is this medication history, crucially important. Probably few things more important. Number two, patient selection. You want to avoid it in low flow states. So you mentioned trauma, of course, hypovolemia, dehydration, any kind of shock, hypotension, congestive heart failure. These are all low flow states. Anesthesia. It's okay to give it during anesthesia or before in otherwise healthy patients, but don't let them get hypotensive, of course, IV fluids, monitor your blood pressure, and so on. Pre-existing kidney disease, cautiously. You can still use them, and it's reported in the literature, but very, very cautiously. Liver dysfunction would be of caution, too. What I mean by liver dysfunction, I mean liver dysfunction. I do not mean elevated liver enzymes. Elevated liver enzymes are not a contraindication for the use of nonsteroidals. The liver issues with cats, I beg your pardon, the liver issues with nonsteroidals in dogs is, number one, rare. Number two, it's not a genuine toxicity because it's not a dose-dependent thing. It's an idiosyncratic reaction of that animal to that molecule. You cannot prevent it. You cannot predict it. So elevated liver enzymes in and of themselves are not a contraindication for nonsteroidals. Liver dysfunction is a different matter. That is because liver failure or liver dysfunction has its own risk factors for GI ulceration, and also you're not clearing the drug out properly. So liver dysfunction, no, but liver enzymes, okay. So that's on the front end, all minimizing the risk going into the use of nonsteroidals. Now we've dispensed them, and what are we going to do on the back end? Number one, the instructions and the discharge instructions, written, verbal, have to be clear about, number one, not adding any other drugs. Don't do anything else unless you ask us. So the dog starts to itch while it's limping, and they give a prednisone, now we're in trouble. So no, nothing else. Number two, to recognize what the adverse events are, and then withdraw the drug and call me. In dogs, what's the number one adverse event? Clinical. Tell me.
Decreased appetite first, then potentially nausea.
So you actually reverse that. Vomiting is number one.
All right.
Diarrhea number two, and then diminished appetite number three. And in cats, it's the other way around. Diminished appetite at the top, diarrhea, and then vomiting at the bottom. So this is the point to make. It doesn't matter. So they're all nonsteroidals, and they have a great appetite, but they spit up mid-afternoon. Stop the drug. Now, you don't know if that's from the nonsteroidal. In fact, it may not be. In fact, it probably isn't, but it might be. And you're only going to get into trouble is if it is, and you keep on giving it. That's where you get into perfs. So ditto a dog that just didn't finish dinner. Normally has a good appetite, just inhales it, but nibbled at the meal and didn't finish the bowl. That's enough. Stop the drug. Call me. So these are the kinds of things that if they know when to stop, you'll take might happen, and then hopefully mitigate anything terribly severe. And that's kind of it. Most adverse events are going to occur in this 2 to 4 week time frame. That's demonstrable in both dogs and cats. It can happen before and it can happen after, but generally speaking, it takes about that long to create a problem, and if they've gotten through a month and they haven't had a problem, generally they're going to tolerate these drugs for a long time and quite nicely. You still have to monitor if it's chronically used, but you can relax a little bit. So all of that stuff on nonsteroidals, that's your frontal cortex stuff. And I know we still have this inherent fear of nonsteroidals like everything else. That's your amygdala, your frontal cortex. So I hope that helps.
That is tremendous. Thank you so very much. Can everybody say thanks, huh?
Thank you.
Thank you. Thank you. We appreciate it so much. We really, really got a lot of information.
Well, terrific. And I look forward to maybe making another stop through there. And if anybody has any questions, Cheryl, you know how to get a hold of me on my email, so they can all individually, if they would like to contact me, just give me a call.
I'll pass it around. Thanks so much.